Good afternoon, everyone. Thank you for joining. We at the Florida Medical Directors Association, we really wanted to get in front and address all things concerning the boosters. And to do that, we've asked Dr. Gaur, Swati Gaur, to come on back and join us again so that she could give us the 411 on all things boosters. I think we all are aware of the situation we're in, and we do know the uphill challenge that we have in our long-term, post-acute and long-term care facilities. So with that, Swati, you could take it away.
Thank you. And I appreciate it. I am going to talk fast because information is coming at us fast. So I'll just begin. I have no financial disclosures, and the objectives were actually put together by Diane. And thank you so much for doing that. So propose. So we are going to discuss the current guidance and the research that is behind the guidance, or where we are finding ourselves regarding the third shot or the booster. Unpack the ethical considerations associated with the boosters. I'm sure everyone has heard about, well, WHO thinks that, this is not important, yet some of the people are thinking that it is. And why, how to sort that out. Identify how we in post-acute long-term care community should be approaching boosters for our residents and our geriatric patients. So I just, I should have actually given this to Ian because I don't know how to work this, but just, you can probably type it in the chat or whatever, but I just wanted to know what is the vaccination percentage in your community. And I'm not going to spend too long, but I would love to know that answer. And I just wanted to say that this is an important consideration. And that's why we need to be super aware of this number. I did want to talk about this very briefly about this MMWR article. This was published in August 24th. What we are seeing here is the following. When you see the number of people number of cases that are occurring in the country, they are primarily unvaccinated people. Similar to the number of hospitalizations that are happening. Hospitalizations is even more compelling if you look at it. I'm going to minimize my, yes. If you look at it, the hospitalizations are even lower for fully vaccinated people. So we need to understand this figure very, very clearly. This is the backdrop on which we are going to be talking. So this is the other question that I have. What is the rate of vaccination of your staff? And please put that in. As well. So the first question was your community prevalence, community vaccination rates. The second question is your staff vaccination rates. And I'm extremely jealous, to be honest, of people who are putting like 95% rates of staff vaccination. But hopefully we all get there. Why is this important? I really wanted, this has been a very, very important slide for us to understand what is happening. What is one of the biggest drivers of what is going to happen in your nursing home? And I can share, while I'm sharing this slide, I can share the story of our nursing home. At the end of December of last year, our nursing home had run out of beds in the COVID unit. We had approximately 28 beds in the COVID unit. We ran out of them. We had to convert one regular floor in addition to that to a COVID unit. We had about 46 residents at the end of, by mid-December and December. We did our vaccination starting of our vaccination, mass vaccination to our residents last week of December. And then, of course, in January. Since then, we recognized that, and I'll go over the data, that it is so incredibly important for staff to be vaccinated. And I'll go over the data in a second. But what this slide shows is the real world reduction in cases if your staff is vaccinated at a certain level. And that's why it's so, so important for us to keep those two numbers. One is your community rates and one is your staff rates, always in the front of on the top of your dashboard. As you can see, the vaccination rates of your staff, once you get to that, 75% rate, you're sitting pretty, even in very high community prevalence rates. So, for example, since the beginning of January, we have had one case of COVID-19 in a resident. That case was a new admission who was unvaccinated from the hospital. Aside from that, we have had 0 cases. Our staff percentages of vaccination had reached 60% in, I want to say, about 4 months ago. Our community prevalence, our community percentage positivity is flirting with 25% right now. And that is, I am always anticipating a positive case, but I have not had it since. So this slide kind of tells us, was the guiding document, why we did what we did is boost up our staff, not boost up, go up on the staff vaccination rate. That was our holy grail. That's what we worked on. The reason was this. This is a study from Canada, in which they basically took neutralizing antibody, which is this last one. And what it shows is the control was your staff, the nursing home residents were your nursing home residents. And after they were vaccinated, if you see the levels of neutralizing antibody titer, which were much higher in the staff and much lower in nursing home residents, which basically tell us that while the nursing home residents are making those antibodies, and look at the number of antibody titers that are kind of here, very, very low. While they're making the antibody titers after 2 doses of vaccine, they are never reaching this level of staff. So your staff is your level of protection. It's like a wall of protection around your nursing home residents. And that's why we really wanted to make sure that we are vaccinating our staff. Now, talking about what happened to the immunity that everyone developed, and this is a slide from the ACIP meeting that was held on August 13th. And what it shows is the effectiveness of Pfizer and Moderna vaccines against Alpha variant versus Delta variant. And what we see here is, in that meeting, it was discussed that United States is more like Qatar's because they use the Pfizer, they use the Moderna, but as you see, the Pfizer vaccine, even in Israel, and that data is coming, the booster data also, Israel is a little bit ahead of us, but they use primarily Pfizer vaccine. Qatar used both Pfizer and Moderna. And what we are seeing is against symptomatic infection, the immunity of Pfizer vaccine against symptomatic infection has been shown to be lower now, 6 to 8 months after. But the immunity on hospitalization and death in general population remains high, as opposed to Moderna, where the immunity against both symptomatic disease and the death and hospitalization continues to remain high. This is important. The difference in Canada and England was attributed to the difference between administration of vaccines. So one of them decided to do a 12-week interval instead of a 3-week interval, and one of them decided to have a 16-week interval, and some of that is attributed to the interval difference. All right. Well, so we talked about the Canada study 2 slides back, and this is what happened in 6 months to the same. And what happened to them is basically, if you just look at this top table, only 2% of controls, which were the staff members in those nursing homes, at 2-week post-vaccination did not have detectable antibody levels. I just want to make sure that there are so many negatives in this statement. Only 2% did not have detectable antibody levels among controls. However, compare that to the residents. 16% of residents did not develop after 2 weeks of vaccination that detectable antibody. And that is the reason why we say that our residents continue to be vulnerable despite getting vaccinated. So in nursing homes where we have much higher rates of vaccination, and the residents tend to do poorly if the staff vaccination rates are lower. Compare that to what happened 6 months later. 70% of the nursing home residents who were, compared to 16% 6 months back, 70% did not have detectable levels of antibodies, which is pretty significant and remarkable, as opposed to the staff members also showed waning immunity, where they went from 2% to 16% of undetectable antibody levels. So this is the data from Israel, and this is the real world data that they talked about. And you could see that the actual rates, and these are basically out from the vaccine periods. So people who got, for example, 60 plus, let's just look at 60 plus. People who got vaccines in January, between 16th of January to 31st of January, had much higher rates of real world cases that you could see. And that is what the Israeli study basically showed us. And as you can see, the less duration between the second dose of vaccine, the lower the rates are. This is the death rates, I believe. Or yes. So this is what we see in the Israeli data that was presented to the FDA. And then they went ahead and they gave the boosters. And this is the Unpack meeting that was held last Friday. And the data was looked at from the boosters. And that data is actually now available, I believe, in NEJM. But what they are showing is after 12 days of booster administration for ages 60 plus, there is a 11.3-fold lower relative risk is 11 times lower against confirmed infection of for ages 60 plus. So essentially, this is the table that I was talking about. This data has been published in NEJM. And which essentially tells us that 11.3 adjusted rate ratio. And severe illness, it is, again, very high. So that is and Pfizer as well presented their data on immunogenicity and reactogenicity. So the immunogenicity is, how well the immunity develops, and reactogenicity is what are the side effects that, they looked at. I do want to point out that the N in these the total number of people is very small. So we have to always keep that in mind. But this is the data that Pfizer actually presented to the FDA as well. And which is what it shows is that it is the immune response in both 18 to 55-year-olds and 65 to 85-year-olds against the wild type and the Delta variant is significantly boosted. All right, so this is the reactogenicity, which is, injection site, local safety data on local reactogenicity, which is, what was the pain, swelling, redness, etc. And if you see, it is comparable or even maybe slightly lower than the second dose. And these are generalized or systemic reactogenicity data, where you do see that fatigue is comparable to the second dose, and fatigue, headache, and all the symptoms were pretty much comparable. So there are two things that we need to kind of question. One is in older adults and in our nursing home residents, there was what we saw is there was, even after the second dose, the immunogenicity was not that high, which could translate to them having higher adverse outcome, which is hospitalizations and death, in addition to symptomatic disease. So, in older adults and in our nursing home residents, what we are looking at is their symptomatic infection, but really we are focused on making sure that they are not having serious illness, hospitalizations, or death. In younger population who are healthcare workers, we are definitely more concerned about not just the hospitalization and death piece, but also the symptomatic and asymptomatic disease. And, that is basically, and the reason for that is, we are concerned that, when our healthcare workers come into the nursing home and provide care to a large number of patient population, we want to make sure that if we can drive down the actual symptomatic or asymptomatic infection or positivity rate in them, then we could somehow be able to decrease transmission to our long-term care residents. So I'm going to basically change gears and talk about the ethical consideration. There has been a lot of talk about, why do we really need to do this? Do we really need to give boosters when the rest of the world is, does not have enough vaccines? Let me back up for a second. And I just wanted to share with you guys, and I'm sure you guys are very aware, the data was presented to the FDA, and the initial vote was going to be, should the boosters be given, initial vote was, should the boosters be given to all people above 16 years of age? But based on the data that was presented, both the risks and the benefits, the committee felt that it did not warrant a blanket give a booster dose to every. We are seeing in communities who have very high transmission rates, and when people who are fully vaccinated, especially younger folks, when they are fully vaccinated, what we are seeing is that they have either asymptomatic disease or they have disease with very mild symptoms, which is a case of almost mild flu. There is a study that was done in Denmark that studied people who were fully vaccinated and how they reacted to the Delta variant. Essentially, what they saw is your CT values will go down. If you're fully vaccinated, your CT values go down for day 1, 2, and 3, which is, a surrogate marker for your viral load, right? And so that means your viral load increases up to day 3, and then it starts dropping. So your CT values, what they showed is the CT values start decreasing day 1, 2, 3, and then they start going up on day 4. And that is a very important consideration to say, what would happen to a fully vaccinated individual, for example, who was 19, 20, 21 years of age, who was not working in a healthcare environment? And the committee felt that the risk and benefit ratio, and we talk about myocarditis. The Israeli data also talked about myocarditis. I was just listening to the ACIP meeting. They did say that of course, the numbers in Pfizer presented an ACIP as well. And they said that the numbers were, although the numbers were small, they did not see any myocarditis in their data. However, Israeli data has reported some myocarditis, and that risk benefit did not pan out for all comers. However, people above 60 years of age, the data was compelling. So I think the second vote was people above 65 years of age who have had, Pfizer shots, and people who may be at high risk for severe disease and death. And now there's this ACIP hearing that is happening today and tomorrow that will determine, the more specifics of who is going to be eligible. So we can't wait. Now, against that backdrop, I do want to talk about ethical considerations. And I think while we talk about these ethical considerations, we're also going to kind of see what are the drivers of the numbers of, or people in nursing home getting sick. So let's look at that. I shared earlier that, WHO is not recommending boosters. And, that is, in a huge part due to the health equity issue that we are seeing globally. And I think we have to recognize that it's a pandemic. We cannot have an isolated island of no transmission unless we deal with the global situation. So we have to be cognizant of that. However, let's think about, what is happening, for example, in Florida. And I'm from Georgia, so what is happening in Georgia as well. I think this is an important slide, and I took it from the ACIP hearing on August 13th. It's a very, very, very important slide. And I just wanted us to focus on the number of cases. So look at the state B, and that kind of is more like our state, more representative of our state. And look at the absolute number of cases. While there are less people in state B, but because of 30% vaccination, a smaller vaccination rate, the virus overwhelms the population. The red dots are the people who are unvaccinated. The blue ones are the people who are fully vaccinated. You have less vaccination, less community level of protection, more transmission, more people are going to test positive who are unvaccinated. But vaccinated people, the absolute numbers of vaccinated people is going to be higher. Although the percentage of cases who are vaccinated may be lower. So it's an important concept that we need to understand, that that's why our community vaccination rate is extremely important to us. So, recognizing this, we in our nursing homes, we decided that we were going to figure out how to protect that resident, whether vaccinated or unvaccinated. Of course, we wanted to drive our vaccination rates in our residents very high. Our residents are about 90% protected, 90 to 93% vaccinated. Our staff vaccination we recognize that in our community, our community vaccination rates are in our county right now are 29% fully vaccinated, and our state vaccination rates are extremely poor. So what we recognized is while to protect our residents, we have two levels of protection. One is your community vaccination rate. The second is staff vaccination rate. If you are able to drive both of them high, you don't have to worry so much about, your resident. I mean, you have to worry about them, but, that your numbers are going to be lower, based on the data that we are seeing. And as far as the staff is concerned, our staff protection truly is that community rate drives your staff protection, your staff rate. So, that recognition is so important. So what we did have in our nursing home, for example, why we had 0 cases is, while we recognized that our community level of protection was very low, we drove up the staff vaccination rates to get that wall of protection for our residents. However, we were not able to do the same for our staff, despite 70% of our staff being vaccinated, they still continued to test positive. I want to highlight how we are, when we talk about vaccine equity, or when we talk about boosters, while we recognize that the global equity is extremely important, and this is a global issue and that needs to be dealt with globally, I want to highlight the fact that currently in the United States, there are 2 different states of United States, 2 different situation of United States. I didn't want to pick on Rhode Island and Florida particularly. I used Rhode Island as an example because their reporting is great. Large number of their nursing homes are reporting to the CDC. These are literally out of CDC. I picked Florida because I'm talking to you guys, and you're more aware of your rates. So recognize that these are actually good numbers for Florida, because you guys have reached that peak. I'm sure that you guys have been inundated with COVID, and I can't even imagine how your summer has been. Look at the community vaccination rates between Rhode Island and Florida, and what happens, how that community vaccination translates into community percentage positive rates, which is, thus far have been guiding, those rates. And since we are so aware of that, I use those. Less than 3% versus, 15% right now, as it is starting to go down. Our rates are closer to, our rates are like 17, 18% in my county right now. But we were, our neighboring counties were in the in 23, 24 range. Look at this nursing home staff vaccination rate. So when I think about community vaccination rate, if you remember that slide that I shared with you that was presented in ACIP with all those red dots, that is the concept that we have to immediately remember and, say, okay, this is what is predicted in our community. When we look at the nursing home vaccination rates, if you look at the difference in the nursing home staff vaccination rates, the difference is 76% vaccinated versus 48% vaccinated. I would love for us to go back to that slide, that Han slide from CDC that said there's 66% reduction in cases. So let's see if this pans out, right? 48%, so, slightly less than 66%. Nursing home staff positivity rate was, let's see. Actually, I think I flipped that, but your nursing home staff positivity rate is, I have this right here. Resident rate was 9% and 3%. So no, actually, I was correct. So your nursing home staff positivity rate is 2% versus 9% in Florida, or 9 per K resident week, rather 2 per K resident week and 9 per K resident week. But look at the number of staff that has been positive in the last month. It's crazy. Nursing home resident vaccination rate, I was surprised to see that in Florida, it's actually 73%. And I think that goes with public health messaging, overarching public health messaging that goes from the leaders of the state and community. And then if you see the current nursing home resident positive, where I got to say that Rhode Island, the curve is actually going slightly up, and Florida's curve is coming pretty exponentially down. And you can still see that despite that, the nursing home residents positive in Rhode Island have been like 1 or 2. And Florida has been fairly high. But this is just in the last week. Nursing home resident deaths, if you look at the deaths, the number of deaths in the nursing home residents is pretty interesting. So that is where I was, that's where I'm pointing to. I think in Florida and in Georgia, we are seeing a different state of affairs. And a lot of it is driven by community vaccination and community prevalence. And so it has become a really interesting challenge, for the, clinicians or for people who are in those states sitting pretty, with very high vaccination rates in the community, in this nursing home staff. It's really, really hard to fathom where the states with low vaccination rates in the community are struggling. And that is, we have to be cognizant of that. Okay, so I did the total United States versus Florida. And as you can see that, that this is Florida on the left. The rates are 73.3% among residents versus 83% in the rest of in aggregate United States, actually. So it includes Florida numbers as well. Vaccination among staff, I'm sorry, this is flipped. This is the United States, 62% vaccination rate versus 47% vaccination rate. Again, that equation flips for you pretty significantly if you look at the data. On the left is confirmed COVID cases among staff in the United States. If you look at it, it's 5.62. The rate is 5.62 versus the rate of 8.68 in Florida. And again, as you can see, you guys have started coming down pretty significantly already from the peak. I cannot imagine what the peak looked like, for you guys. The nursing home resident rates, as you can see, significant difference in nursing home resident rates between United States with 4.25 versus 9.21. And these are the deaths. And as you can see, pretty significantly high. I mean, out of the whole United States, week ending September 12th, 551, 64 were contributed by Florida. I mean, if we think about it, it's pretty astounding. There are some other factors that are play into this. Vaccination is not the only thing. One of the things, these are the two facilities that I had. And as you can see, Facility 1 and Facility 2. Facility 2 actually had less number of residents. So if we actually started doing rates, these are absolute numbers. They are up and down the same road. But if you look at the number of aggregate cases, that is from the beginning of the pandemic until we got vaccinated. Because after vaccination, we had one resident positive between the two facilities, and that was an admission from the hospital. If you look at it, there is a significant difference between the numbers. So PPE use, masking actually makes a difference. These are the things that we used before we had the vaccine. PPE use makes a difference. Cohorting appropriately, staff, residents, and equipment, and staffing shortages. The worst cases, increase in cases in Facility 2 happened in the setting of significant staffing shortages. And my point here is that that staffing matters. So even if our staff is going out with being positive and we are not seeing significant staff deaths, in fully vaccinated staff, it still leads to staffing shortages, which in turn leads to increase in number of cases, could lead to increase in number of cases. So that's what my point is. So keeping that in mind, AMDA actually sent a letter of request to ACIP to meet as soon as possible with the data that they had to make a determination and give us guidance on giving the booster dose to our residents in the long-term care facilities, and also have consideration for staff vaccination. So that happened as soon as we got the data from the Canada study that we had quoted in the letter. This is from the ACIP hearing today. Actually, Dr. Slayton might be talking while I'm talking because her slot was right now. So thankfully, the slides were shared about 15 minutes prior to our meeting right now. And what she is going to present is also the fact that, this is the total symptomatic and asymptomatic COVID-19 infections among the residents. And if you look at this slide carefully, on the left is your importation rate. Importation rate is correlated with your community, percentage positive or your community incident rates that CDC is now reporting. So this is an area of, let's say this is Rhode Island. And if you see, the mean number of infected residents after 2 months. So the higher, the bigger the red, that's the higher number of symptomatic and asymptomatic residents, right? Here is basically what it is showing is you may give boosters. This is after the boosters. You may give boosters, and after the booster, on the left is the no booster. On the left is the no booster. On the right is booster. This is modeling data. After 90% people have been of residents have been vaccinated, and this is when 90% of the residents have been vaccinated, but look at the staff vaccination coverage. And so what it is showing is if your staff vaccination coverage remains low, even when you provide the booster, you are only going to be able to prevent the disease in your residents if your community prevalence is high. Like, let's say this is Georgia or Florida, and let's say this is Rhode Island. Rhode Island, like literally, we are still not able to reach here despite boosting all of our residents in low staff vaccination coverage. So my point, my moral of the story from this slide is that community prevalence matters and staff vaccination coverage matters. So this is her final slide, which says maximizing COVID-19 vaccination among staff remains a critical tool for preventing cases in nursing homes. Booster for nursing home residents can help reduce cases. Magnitude of effect depends on the effectiveness and staff vaccine coverage. Even with highly effective boosters, cases in nursing homes will persist when community transmission is high. So we will see between today and tomorrow how the ACIP committee is going to make determination on essentially staff vaccination, staff booster vaccination. I firmly believe that, after the FDA approval of the EUA for a booster for high-risk patients, I believe that we might be able to get a booster dose for our residents. I am very interested in seeing how the committee determines staff vaccination and which side does it come to. I would love to go back to this slide that I keep thinking about. We can boost their immunity and they would be having a better hospitalization and death advantage. But in a community with poor vaccination rates, my question is, should we boost the immunity of the currently vaccinated staff so that they have the benefit of transmission? And that is going to be an interesting question to answer. So that's where we stand on the boosters and the discussion on boosters. So I think we may know something totally different by tomorrow afternoon. That being said, I wanted to go to how do we prepare? So knowing what we know now, how do we prepare for boosters in long-term care? Our current unanswered questions, which I'm sure will be discussed, is, does the data of Pfizer vaccine apply to Moderna? And what we have seen in the past slides is Pfizer vaccine had more waning of immunity seen for symptomatic disease, but the death and hospitalization advantage was maintained. That is as opposed to Moderna, where the symptomatic disease advantage is pretty well preserved compared to Pfizer. And the reason for that could be two. One is dosing interval, and that could point to, if you remember, the data from Canada and from UK was slightly different, with Pfizer showing a better preservation of immunity against symptomatic disease. So we know that the data of Pfizer, the contributing factor people think is, one is the dose of mRNA used in Pfizer is slightly smaller dose than Moderna, and the dosing interval, as we talked about. So we know that the data is different. My question is, how is it going to pan out operationally? Are they going to say only boost Pfizer, or boost all vaccines all across the board? So that's going to be an interesting question to answer for ACIP. And then the other question is, do we give the same vaccine or a different vaccine is acceptable? So there are two things about heterologous vaccine. Lancet has published studies on heterologous vaccine administration on both reactogenicity and immunogenicity, but they used, obviously, their AstraZeneca vaccine. And what they had shown is if there is a heterologous vaccine, for example, you used AstraZeneca first and then gave the Pfizer, the reactogenicity is slightly higher with increase in Tylenol use and increase in reporting of body aches, generalized symptoms, and localized symptoms as well. What about the immunogenicity data? So compared to the 2 doses of AstraZeneca, the 2 doses of Pfizer were better. However, the AstraZeneca plus Pfizer was slight bit better than both of them, is what they have published. Now, those, again, small studies. There's a large trial that is being conducted by NIAID, which compares all the vaccines that are available to us right now, and they are looking at the heterologous administration of those vaccines. So that data should come out. And I'm eagerly awaiting that data as well. And I'm sure that we know that the Johnson & Johnson vaccine, Johnson & Johnson just came out with their vaccine data on 56 days and 6 months. And basically they show that there is benefit in giving 2 doses. And doses given at 6 months have a higher benefit. So that'll be interesting data to look at as well. So that is, what we have on the road, what we have to anticipate as we go forward. Okay, this is an important topic that I just wanted to highlight, that ACIP and CDC basically are suggesting that co-administration of influenza vaccine and COVID vaccine can be done. What we have done is we have decided to co-administer the vaccine, the boosters, and the influenza vaccine for the residents, as we had seen very, very limited side effects or reactogenicity when we gave the second dose and the first dose of our Moderna vaccines. So we feel comfortable. We are asking the families, but we feel comfortable doing co-administration. Remember, if you are going to use high dose flu vaccine or more potent flu vaccines, they're recommending different arms, different limbs. To be used because of the side effects. In the staff, though, we are giving the staff the choice of either taking the flu vaccine and COVID vaccine together, or doing it at different intervals depending on how the staff feels. Because any adverse reaction in the staff or the perceived reaction in the staff does something to the morale of the rest of the staff. And we are in an area of 29% vaccination. And I laughingly often say that misinformation quotient should be a real thing. And we have a very high misinformation quotient in our community. So we are going to actually break it down for staff if they don't feel confident. Okay. Vaccine logistics. Your team is going to be consultant pharmacist, your DON, nursing leadership, medical director. And here are the things that I had, we didn't have the pharmacy program. We decided to in-house our vaccine efforts to begin with. And these are the lessons that I had learned. So I have just done check boxes. There is a very good resource that is available. on the AMDA website as well. And in the bottom, I have actually basically given the clinical consideration managing anaphylaxis. That is a very, very important piece of information to educate your staff on observation and assessment of anaphylaxis, because it's not going to be always a huge rash and a swollen tongue. It could be nausea. It could be, I feel dizzy and people passing out, etc. Make sure that you have your e-kit available for vaccine. That is also on the website below. And then staffing logistics. We used a lot of light duty staff to do observation, and we did hallway by hallway. But it is a very, if you prepare well, it's going to be a fast process. So that is it for me. And I'm going to stop sharing my screen so that we can see what's going
on. Thank you, Swati. Thank you. I think I'm trying to see if we had any more questions. Some of the questions were more comments through the chat, but if anyone has any questions, we do ask you to take yourself off of mute and please ask. I'm going to start with one for you, Swati. Looking at that ACIP slide, the first one that you shared, here in Florida, we have a staff vaccine hesitancy or confidence initiative that we've been promoting. From that slide, it seems like we need to double down on efforts to really get the staff vaccinated. And as you said, it's Florida. We are a special case like Georgia within the country. What have you seen that is working to get the staff to agree to that shot of the arm?
Yeah, that's a great question. And thank you for asking. I mean, if I can just shamelessly brag, because, we have been working so hard on this. Our vaccine rates in the community are 30%. Our staff rates without any mandates or even any kind of incentives had already climbed to like 70%. So that's a 40-point differential, in a community that our staff is living. What was the difference? One thing that I can say, Diane, leadership matters, and you and I are suffering from the fact that leadership matters, on vaccines, on masks. So I'm just going to have to come out and say it. I think we need to stop being afraid and just, be vaccine forward. So one of the things I think that we achieved very early on is that leadership of the facility. There is not a single person walking in the facility that doesn't know that if they talk to our administrator, if they talk to our DON, if they talk to our nursing leadership, if they talk to me, if they talk to any of the clinicians, that conversation about vaccine and the benefit of vaccine and the studies of vaccine is not going to come up. So in essence, we are very vaccine forward leadership, and we made that determination. And the reason for that is one, I'm a huge gardener. One thing that I know that the reason that the way that you can decrease the weeds in your garden is grow healthy plants. Your brain is a very, very, valuable real estate, and misinformation is leaps and bounds ahead of us. So there has to be a constant and continuous push to replace and elbow out that misinformation by real data from the clinical leaders in the facility, from the administrators in the facility, from the DONs in the facility, create your tribe, create your vaccine forward tribe. We have CNAs, we have food service workers, we have, we created this tribe of people who constantly talk about, but this is what the data shows. And we share that with all departments, town halls, like incessant town halls, bringing them in. Tough town halls, because we had EVS and food services who would not come to our town halls. So then we went and reached out to their VP and said, please, can you get us in front of them? Very, very tough meeting, very contentious meeting. Here is the thing. we sat down with people who were unvaccinated. Out of those people who were unvaccinated then, over 70% of those people are vaccinated, despite having a contentious meeting. So don't think that everyone is going to agree with you, but I think that giving constant information matters to our staff as well.
Now, I know we're running short of time, but I heard you mention on a call on another talk about people who may be jumping the line and try to look for a booster shot. And I'm not going to tell you how many people I know who have done that. No one has to disclose that. But we have states like Leslie Eber's on, and we have states like Colorado where they're already giving boosters to healthcare workers. And I'm not sure if they're doing it for residents, but what do? We don't know what the FDA, we don't know what the CDC is going to recommend and what the FDA is going to decide. Yes, it is the Wild West out in Colorado, but this is the Caribbean. We're dipping into the Caribbean in Florida. So, what do you recommend?
So I think after I can tell you that I started out with my. I have always I wanted to get a booster so bad. And full disclosure, I've not gotten a booster yet. Would I love to get a booster? Yes. I hope that ACIP comes out on the side of giving healthcare workers a booster. Would I, after listening to the FDA hearing, the Unpack, would I give it to my children? I was very, so I have a 17-year-old and a 23-year-old. The 23-year-old lives in Massachusetts. The 17-year-old is fully vaccinated. They have mandatory masking in their school. I am going to have to do a risk benefit. And I don't think that after listening to the Unpack committee meeting, I'm going to recommend that my kids take the booster because they're younger, they're doing the other things. Their school is actually using PPE, et cetera. Yeah. So I would not recommend them getting the boosters.
And I think I come down on that side too, because I feel like when you're at higher risk, because you're in a facility, you're in the hospital setting, you're seeing patients, wherever you're seeing them, it puts you at a higher risk. And so everyone in our facilities would probably be at a higher risk, and we should take different considerations. But those who are young and making great immune reactions, maybe we should think differently. My biggest concern is the information and the data that we still need to really receive and understand about the long hauler symptoms, because if we're getting such dramatic outcomes with those who are in their 40s and 50s, should that age requirement be dropped? That has been the thing that's sort of like keeping me awake, making me read at 3:00 in the a.m.
Yeah. I think it all will have to boil down to where are you living? Where are you living? What is your risk of acquiring the disease? And, ending up that long hauler symptoms, right? I mean, I know that the data in Israel is over 60 years of age. If a 60-year-old is going to come to me and say, I want a booster, I'm not going to say no. There's compelling data. Of course, after the ACIP hearing, I would never recommend anybody do anything that is outside of the bounds of, what should be, what our ACIP and our organizations that we trust say. But yes, I mean, definitely for a younger generation who is especially living in Massachusetts, I'm not going to recommend a booster. I think that's overkill.
Thank you. Well, thank you for your time today. This was wonderful. This recording will be available, and we'll make the slides available too. So thank you, everyone. Have a great day.
Thank you so much for having me. It's always such a pleasure, Diane.